Welcome back. So far, we have done 2 days of a lot of good lectures and information. Now this particular section, it will be a different one, a different type of presentation. We're going to start, and we're calling it as a panel discussions. Jasmine Ahmed, who is Dr. Jasmine Ahmed, is in clinic. She is working in the psychiatric department at the Larkin Hospital. She is going to present a clinical case. The clinical case that she will present, we as a panelist is going to dissect that and information. The process of diagnosis is going to be manifested into this particular case presentation, not the diagnosis itself. So that means our purpose is to not to provide management and diagnosis of particularly this case. So it will be more, what else? You got it? What else? Why? What are the thought process? This is actually the model by which the clinical education is necessary to put in. When we was doing this, why we have to do this thing, we realized that there is a big gap in our educational model where we do not use the why rather than just give lecture. Okay? So that's what we are coming to. I hope everybody is come inside. Whoever is outside now, we're going to start. Now I'm going to invite Dr. Jasmine Ahmed to provide the clinical case.
I'm not able to get enough sleep, and it's getting worse. So it's a 63-year-old white male. The patient has recently been falling asleep at work. The patient has a very high demand job, works at NASA, and lost his job 2 weeks ago. The sleep difficulty started 2 years ago, however, during his divorce, but now has recently become worse over the last 2 months. He describes a latency of 30 to 45 minutes, and he wakes up every hour or two, and sometimes it can last 15 minutes to more. On average, he was getting 4.5 hours of sleep for the last 1.5 to 2 years. However, it has shortened to 3.5 hours over the last 2 months. The patient now takes frequent daytime naps. He feels on edge, he's worried all the time. At night, at times he gets racing thoughts. Sometimes he wakes up and he has this sensation of choking, except this sensation has only started as of 4 weeks ago. He states that there's no change in seasonality with his sleep. His basic hygiene is good. He goes to sleep around the same time every night, wakes up at the same time, and does not bring work into the bedroom. So he also describes himself as a very type A personality. He denies any mood disturbance, and he also denies any of these hypnagogic, hypnagogic hallucinations right before waking up or going to sleep. He denies sleep paralysis. As far as his past medical history, he has quite a few here. He has hypertension for the last 20 years, treated on 3 hypertensive medications. The patient is obese with a BMI of 36 that has jumped by 2 points over the last 2 years. of his coincidence of his divorce or what, but he does have hypercholesterolemia, treated with statins, tension type headaches, and COPD. Now, his COPD, he had an exacerbation about a year ago that required hospitalization with this patient. The patient has to drink several caffeinated beverages, according to him, about 3 to 4 a day to keep up with his work. Smokes tobacco, about half a pack a day for 30 years, and drinks alcoholic beverages. Now, this is subjective, as you know, you have to ask. 2 beers a night and more on weekends and at social events. He denies recreational drugs, however, does admit to over-the-counter use of sleep aids frequently. The patient does have a past psychiatric history of a major depressive episode with some perceptual disturbance. 2 years ago, treated with antipsychotic medication, currently no longer on medication. As far as the family history, the patient has a mother who's 86 years old and has history of insomnia, which is here. Father who is 90 with a history of coronary artery disease. In the physical exam, most of it was within normal limits. However, there was 1+ edema in the lower extremities, some hyperresonance in both lung fields, and some mild wheezing. Also note there's some varicosities in the lower extremities. The patient did have a sleep study done 10 years ago, which came back negative. CBC is positive for anemia, and the vitals are normal except for an elevated pulse of 103. Urine toxicology is negative, and the patient has tried diphenhydramine and glucuronide. As far as the mental status, the appearance of the patient is well-groomed, hygiene is well, the gait is good, and the posture is upright. The behavior is cooperative with proper eye contact. There was no psychomotor agitation noted. Speech was very fluid, normal rhythm, normal rate. Mood as per patient was okay, but tired. Affect is congruent, euthymic, and with full range. Thought process was organized, linear, goal-oriented, and the thought content didn't include any psychotic, delusional, or suicidal thoughts. Insight and judgment was intact. His memory was good with a mini-mental score of 28 out of 30. Concentration also intact. So what's keeping the patient awake? So multifactorial complications of maybe chronic medical conditions. Maybe this is acute on chronic nuance in sleep apnea, even though the sleep study was negative. That was 10 years ago. Patient has, over the last few years, increased 2 points in BMI. This could be the case. Patient also could be suffering from CHF at this point. Long history of COPD. Complications of psychiatric disorders. Patient has a significant history of major depressive disorder. Maybe this is maybe it's a reemergence of the psychiatric condition. The social habits of the patient include alcohol use, tobacco use, poor lifestyle choices that can affect sleep. The patient also has a lot of high type A personality and tends to work too much. So that can also affect their sleep hygiene. So now our panel is going to elaborate a little bit more on certain aspects of this case. And I'm just going to briefly say what they're going to be. So the medical conditions contributing to disordered sleep, insomnia can impact psychiatric disorders, novel markers of sleep physiology, and wearable technology for that, pharmacological interventions, and a little bit of the pathology behind insomnia.
All right. Now I'm going to come down to the real world. Real world, this particular patient needs questions. One of the things that is the patient is presented with an age, and it's a male. Now, immediately in family medicine practice, we can jump into a conclusion and make the diagnosis. The problem is, if we keep on doing it, we will not know what is the detailed history about choking. This particular patient has hypertension. Patient has choking. What do you mean by choking? Remember that we have to return back to the patient to clarifications. Now, in this case, the clarifications may be choking is choking, or I can't breathe and I jump up from the bed, or I'm so much into shortness of breathing at that particular moment that nothing helps me other than drinking some water. Very practical way, patient may say. That can indicate paroxysmal nocturnal dyspnea. What is pathognomic of the right heart failure? Paroxysmal nocturnal dyspnea. We may totally ignore that one if we only look at this case and get to the diagnosis. Now, once you have a patient who has paroxysmal nocturnal dyspnea, it is our responsibility to look at this patient. What we are looking, this patient apparent in the daytime, perhaps there is no other features than the short neck, obesity, 37 BMI. That is significant. Now, this patient is a high risk. I'm going to put my stethoscope on this patient and I'm going to identify is this patient has a heart failure. What will be indicating for me to analyze is third heart sound, because it is pathognomonic. What I'm trying to say is that if it is a paroxysmal nocturnal dyspnea and you have third heart sound, you are definitely dealing with right heart failure. Now, you look at the jugular vein and it is distended. You want that patient to lie down. When the patient is lying down, you are pushing in the hepatic bed and you are trying to find out if jugular vein has some kind of influx. And if there is no influx, that is a solid tumor somewhere is sitting there causing a superior venacle obstructions. But you see that there is continuity, but it is enlarged. That is a right heart failure. Who gets more right heart failure? Obstructive sleep apnea. Now, I am not trying to give a lecture, I'm trying to analyze this case. And when I'm going to look at the pulse, I'm going to figure it out if it is irregular. With all respect, most of the time we put a machine in my office also. I'm also do the same thing. Blood pressure, pulse, respiration, everything automatically comes in. Here's a clue. You put your finger on the pulse and it is regular. What are you thinking? It is regular? No. Put a stethoscope on the chest and now you check the pulse both simultaneously. You find out there is a deficit. What is happening? It is regularly irregular. When it is regularly irregular, am I dealing with arrhythmia? Or there is a gap between SA node and AB node. Impulse is now delayed. So you cannot identify that until you put an EKG. So I'm going to do the EKG. But I want to see what I'm looking into the EKG. The patient is only choking. You know, no insurance company can pay this, what is in the back of our head. Thinking. So you do the EKG and you said, well, what I'm going to see in the EKG if there is a right ventricular hypertrophy? Then I'm going to look at the V1 to V6. And I look at the V1 to V6. And I don't know why I'm looking at the V1 to V6. Only I know that the EKG was invented when Ipnovan put his leg on the water. Remember? Ipnovan said that there is a triangle. That triangle is created by Ipnovan to analyze the EKG where he said, and it is many years before, that you put a positive electrode into the surface of the body. If the vector of the heart is going towards that electrode, it will give a positive deflection. Alright? If it is so, then look at that, where is my positive electrodes are placed? It is in the left side. Left arm has positive. Left leg has positive. So now, the vector is supposed to go this way because the heart is located in the left side and this way. Dr. Adi Goldberg, you know Dr. Adi Goldberg wrote a very beautiful TKG book, only this much. Dr. Adi Goldberg, first time, he said that this 3 days is not enough. I want to see the whole heart. That's why the augmented lip came. AVR, AVL, and AVF. But these are all limb leads. Going back to my point. Then the V1 to V6 are all positive. So if that is true, that vector is going to go towards the positive pole, then V1 is located in the right side of the sternal border, at the fourth intercostal space. So the right side of the heart, if it is enlarged, I am going to see a deflections of the vector coming towards the right side. I will have a tall arm. You see? But if it is a normal heart, a normal person, I will have the vector is going towards the left side, so V1 will have a small r, and V6 will be large r. That is called R progression. Little baby of the R is ultimately going to the bigger one. So if this is the case, 63 years old, I am doing the EKG and I see the tall R in V1 or V2. I will say, my thought is working. This patient has a right ventricular hypertrophy. But why this patient will have right ventricular hypertrophy? Remember that right atrium gets the blood from superior vena cava, inferior vena cava, and ultimately comes to the right side. Right atrium gives the blood to the right ventricle, and the right ventricle gives the blood to the lungs. The lung is already full, or stiff, or high pressure. What it will do, it will give the back pressure to the right ventricle. The right ventricle will give the pressure back to the right atrium. I will have a jugular vein distension. You follow me? So ultimately what really happened? This patient had choking or shortness of breathing. My panel is saying that, oh my God, if you give the lecture, we're going to talk what? Okay, wait, I'm going to stop and then I will go back to them and then back to again. So what really happened is that your right side of the heart is actually, as a parameters, it assesses, it gives you information about the lungs. That's why many years before, when there is a lung volume is causing that, lung causing the heart to fail, we used to call pulmonary. Don't forget that. My God, we are all forgetting. Every time something happens, we are just referring. No. That days are over. Be a doctor, because the specialist is not going to help. I'm sorry, specialist is here, so they will help you, but your assessment has to be there, bedside. So ultimately what happens here? We have a patient who may have right-sided problem, and that right-sided problem remember superior vena cava, where it ends, next to it is your SA node. So SA node is going to give the impulse to ultimately provide that to AV node, and AV node to the ultimately to the ventricles. So SA node is the big time impulse there with the parasympathetic. Keep in mind, if the SA node to AV node is 0.20 or more, you have a dissociation between the SA and AV. We are talking about first degree. If the first degree ultimately continue, and somebody is drinking and smoking, all right? Somebody is taking drug. They say marijuana is not drug. Please, I don't understand this. I go there and come out. Okay? What is happening for every drug that has been invented? Means drug means street drugs. They are designed to use sympathetic. You understand? Sympathetic and parasympathetic, when they are clashing, remember sympathetic is the mother. Sympathetic is the mother. Mother means it provides, it is the dictations by the creator. You must have that one so that you can sustain life. Parasympathetic, other hand, is your emotions. Neighborhood, that's the story. So, bottom line is that when you are clashing that, you are exciting the other factors and you are causing a rapid successions of the heartbeat. Now, when that person is go into the sleep, that's why I was saying one part of our life we don't know. The clinical picture is totally goes into the bizarre. That moment, the patient actually going down and dead. Okay? There is no impulses coming out. Remember that, that's what all these 2 days we have learned. During that time, when there is a hypoxia, hypercapnia start high. So hypoxia causes what? A disharmony between the SA node and AV node. Actual relation starts because now the heart goes back and jumping. Look, the lectures after lectures, we know that it provides a abnormal slowing of the heart and then it increases that, right? That is the moment you are going to create a sudden death conditions. All right? So 63 years old patient came in. Dr. Sai is a professor of pharmacology and he's now here to talk about some of the medications that can be appropriate or how that works.
Thank you, Dr. All right, so we're in the School of Pharmacy, and then all of us have heard excellent talk, especially Dr. Nawaz yesterday. So I'm not going to go into detail pharmacology, but I've prepared this lecture from the perspective of a pharmacist. So I'm just made to discover that some of these slides are borrowed from some of my colleagues who are expert in pharmacology. So my own lecture notes and some open source educational website. And I thought that it's prudent to have a talk focused from the perspective of a pharmacist. So pharmacists take the NAPLEX exam, this National North American Pharmacy License Exam. So the drugs that are more commonly tested, I've included them in this talk. And then I like reading history. So I've actually put together some interesting facts. So hopefully that will keep you awake and then we'll enjoy this lecture. So I like to always go back to the basic definition. So we use sedative and hypnotics to address some of those sleep disorders. So sedative, it's a calming agent. hypnotic agent to stimulate sleep, and anxiolytic drugs, as namely control decreasing anxiety. Okay. So these effects are accomplished by several types of drugs that include CNS, depressant, non-benzodiazepine anxiolytics. Now there are research nowadays, and there are some other antidepressants and even beta blockers. So sedative hypnotics suppress CNS activity. They are pharmacologically diverse, and depending on the dose, the effect will go from calming to sleep to unconsciousness if you're not careful. Especially the drugs that have a very narrow therapeutic window, it causes coma and lead to ultimate death. So we have anxiolytics, hypnotics, anticonvulsant, muscle relaxant, anesthesia induction, and I'll go over as follows. So again, I'll just quickly go over. We had a pretty nice discussion yesterday. So almost all hypnotics and sedatives work on the nervous system. So gamma-aminobutyric acid is a natural inhibitory neurotransmitter in the CNS. Now, so it binds with GABA and then opens up that chloride channel and then results in all of the pharmacological effect. Now, I'll come back to this slide. Just take a look really quickly right here. So it's a pentamer. It's a pretty large molecule. So it's a pentamer. It's a pretty large molecule. You will notice that now we have made decent understanding in the advancement of molecular biology and crystallography. We actually have pinpointed where each drug binds. So Tulane University website, they actually contain a pretty nice database on neuropharmacology and the drugs that their structure has been resolved, where they find how they elicit their pharmacological effect. So yesterday, I recall there was a question regarding the difference of mechanism between benzodiazepines and barbiturate. So benzodiazepines, they are allosteric modulator. They actually help GABA to bind strongly with the GABA receptor, and this is pharmacological response. On the other hand, barbiturates are actual agonists. They actually enhances the effect of GABA significantly and keeps the chloride channel open. And then if you're not careful, that can lead to death. And this is the major reason why barbiturates are not very commonly prescribed, and the benzodiazepines become more favorable. So again, as I mentioned, life reading history. Again, we keep our pharmacy students entertained with some secrets from the history. So from centuries ago, still alcohol has been used as sedative hypnotics if people have not become sensitive. And then opium, and then you look at some culture from Africa, they still use some alkaloids to induce hypnosis. So the first, form of what I call a chemical substance that was, we knew very well was sodium bromide salt that was used as sedative in 1800. Then actually came chlorohydrate. That's actually a derivative of alcohol, drinking alcohol. Now it actually has a very interesting history. So in 1903, there was a bar and restaurant in Chicago. The bartender name was Michael Smith, and he was called Mickey. So in that bar, they would actually look at the customer. If the customer looks well affluent, they will slip some of those, Mickey, and then the person will become unconscious. They will rob them and they'll dump the body in the alley. So this case will actually become very popular, and the Oxford Dictionary actually included that word in 1915. So chlorohydrate is actually also known as Mickey, because in or knock-on drops. So I found that history to be very interesting. Then came para-aldehyde. So there were two introduced in, they were made in 1880, and then they actually come to market from 1890s, and they were used until 1903. Then came the barbiturates. So again, they were prepared in 1864 with the advancement in chemistry. So the problem with the barbiturates were the safety, and then the slight overdose that can actually lead to death. And then eventually they were replaced with benzodiazepine. Now, the major victim of barbiturate overdose was Marilyn Monroe. She died in 1962 due to the overdose of barbiturate. And Rolling Stone actually wrote a song. It's called Mother's Little Helper. So I'm not going to sing the song. I sing horribly. So, but these drugs were actually prescribed heavily to the women for any common disorder. They were anxious. They were feeling tired. They were just popping pills. So Rolling Stone wrote a song, and I'll just read you two lines, and you will see the mindset at that time. So mother needs something today to calm her down, and though she is not really ill, now this is important. and though she's not really ill, but there's a little yellow pill. So it was the mindset at that time that just pop a pill and feel better, pop a pill and feel better. And then, that actually took Martin Monroe. I mean, you can imagine she was a celebrity and then, dealing with some psychological issues, and then she just overdosed and then died of barbiturate toxicity. So barbiturates today, we still use barbitol, use it in Wilson. So now we have some ultra-short acting, newly synthesized barbiturates for anesthesia induction. Also, we can find a barbiturate called butalbital and furanol, furosemide, and estate. It's a combination of 3 drugs: butalbital with aspirin or acetaminophen as an analgesic and caffeine as well as a stimulant. Now, furosemide, number 3, has actually codeine in it. It's a controlled substance, and then still is in use today. Then in the 1950s, a major anti-anxiolytic or tranquilizer was introduced called methylbromide. So again, you notice that when I was looking for some information, I noticed very unusual, very interesting actually pamphlet that were published and they were marketed to the women all again. So this drug is called Miltown. So housewives across the nation actually quoted from the newspaper that were being prescribed Miltown for insomnia, anxiety, and emotional upsets. And there was even a poster that says menopause doesn't need to be depressive. So for almost any condition, they were just selling Miltown left and right. And then came the benzodiazepine. So the first benzodiazepine was brought to the market in 1957, called Librium. It had a hypnotic and sedative effect, worked very well. It was less toxic, and you notice that it says that more accessible and communicative. So it will not knock a person off. A person will still be able to keep their function. So it has superior efficacy and safety. And then they become hypnotics of choice. So then came Valium in 1963, and I must tell you that my mother even used Razepam. I mean, still it's being used sometimes. So there was actually a movie made by the movie called I'm Dancing as Fast as I Can. So again, benzodiazepine have issue with habit formation. So Barbara Gordon, she's actually an Emmy Award-winning documentary filmmaker. She actually herself suffered from the addiction and problem with weaning off from the Valium. So this is actually a pretty interesting movie. Actually, my professor showed me during our pharmacology class. And I'm going to shamelessly market my book. So I wrote this book, Social Aspects of Drug Discovery, Development, and Commercialization. We wrote a whole chapter on the tactics that pharmaceutical industry use to market drugs. So you notice that those interesting pamphlets they're telling women, take this drug for this, and then helping them just like candy. Even today, if you watch the commercial, you will notice that as the healthcare provider, this drug is right for you. And then the patient will expect that physician will prescribe that drug, not realizing that the patient has to look at the whole person, there are other problems, that drug might not be suitable. And if the patient doesn't write that prescription, the patient will think that the doctors are not doing their job. So I wrote a whole chapter in my book talking about ethics of marketing the drug to the patient. So the PAMs, benzodiazepines, there are hundreds of them out there. And if you look at pharmacology generally, you will notice that there are tons of synthetic benzodiazepines in the market. In research phase. And then 49 in the US market. I checked the day before yesterday, and this is the most up-to-date list. So the drugs that are in those signs, they are actually no longer branded. Now they are off patent, and you can buy them from generic sources. So then we have now new drugs, we call them Z drugs, as we heard yesterday as well. So they have replaced, benzodiazepine. They're safe, they're short-acting, they're usually non-habit forming. They have very similar effect. They have different binding sites on GABA site, but then, as I said, they tend to be, not habit forming and, rather much safer. I think that pretty much ends my talk. I think you can take questions and answer.
Again, we are still into the process of analyzing the case. We learned some of the medications now, but what is the next step on this patient? What about if this patient is not needed any medications intervention because of the psychiatric conditions? It may be something to do with the patients with the COPD. This patient is a smoker. Okay? Now, if the patient has a COPD or patient have asthma, I'm just saying that both, like one is the obstructive airway disease, another is the fibrosis of the lungs. Pathology is completely different, but the end results in case of this particular case is going to be 83% risk of that, because we learned from the last 2 days that how it becomes a very complicated issue when somebody has respiratory problems at the top of the sleep apnea. This particular patient is going to go to the sleep study, definitely, okay? But don't forget to analyze the lungs. Now, when we are going to do the lung study, we have to know the spirometry. You know, basic spirometry, if we don't know analyzing, then we will not be proceeding forward, okay? One of them is that just a complete normal stethoscope examinations on this patient. Normal breathing of a person is there should be inspiratory sound will be prolonged, then expiratory sound should be quicker, okay? So inspiratory sound and expiratory sound, if your ear is not going to analyze that properly, you will not be able to figure it out that the patient have equal or prolonged expiratory sound, which indicates the patient have obstructions in the airway. Not wheezing, okay? Wheezing is not, all wheezers are not asthma, okay? Remember that? So you don't wait for the wheezing, you check the expiratory sound. In this patient, expiratory sound is prolonged. So this patient has some kind of fibrosis or some kind of obstructions, all right? Now, that obstructions cannot be analyzed by expiratory